On it. Bismillah ar-Rahman ar-Rahim. We are now going to start with the Medical Retina Symposium 1 Anti-VEGF Updates. I'll request Professor P.S. Maher to come and occupy the chair of the chairperson of this session, as well as Professor Rao Rashid Kamar. I myself will act as a moderator. So, first of all, the presentation is mine on the association of the retinopathy with hypertension and diabetes, mellitus and hyperosity. Can I start, sir? Bismillah ar-Rahman ar-Rahim. Now, this is a very brief and short presentation on the association of the diabetic retinopathy with hypertension and diabetes mellitus type 2 in hyperosity. Now, the purpose of this study and exercise was to evaluate the association of hypertension and diabetes mellitus with diabetic retinopathy. Of course, diabetes mellitus is a major health problem. Among 140 million population of Pakistani, 7 million people have diabetes mellitus. WHO estimation for prevalence of diabetes mellitus in Pakistan is 8th in the world. By 2025, expected to rise to the 4th position. Diabetic retinopathy is the major cause of the blindness, visual impairment. Macular edema is a manifestation of diabetic retinopathy that produces loss of central vision. And there are various associations and risk factors: the duration of the diabetes, poor metabolic control, hypertension, pregnancy, and nephropathy. Now, improved understanding of the role of hypertension and duration of diabetes mellitus in the pathogenesis of diabetic retinopathy provides an opportunity for ophthalmologists and other diabetic healthcare professionals to improve the healthcare, good result in effective treatment. Now, 438 patients were studied, and these were selected from the retina clinic, which is being performed at Khairpur Medical College. After thorough history examination and laboratory investigations, we selected the cases of diabetic retinopathy, diabetic macular edema, proliferative diabetic retinopathies, and advanced diabetic eye disease. Now, among all these patients, 438 patients were selected. Male were 270, that is 61.64%. Female patients were 168, 38.35%. Age 14 to 75 years. Mean age, and this is actually the study of diabetes too, but some young patients were also with diabetic retinopathy, they manifested, but they have been included. But we have just studied on the diabetes mellitus too. Now, mean age is 51.63, and above 40 years of age were 408 patients. 93.5% were above 40 years of age. Now, duration of the diabetes was maximum up to 30 years, mean duration 11 years, and hemoglobin A1C was found in 324 patients, 74%. Means uncontrolled diabetes mellitus. Hemoglobin A1C in 324, it was increased in 324% patients, 74% of the patients, and 50% of the patients were 221 in number. 50% of the patients were hypertensive, and hypercholesterolemia was seen in 13% of the cases, and the nephropathy, the increased urea and creatinine levels, was seen in 3.19% of the cases. Now, when we treat diabetic retinopathy, we only see the physical picture of the retina and we start the treatment. If there is diabetic macular edema, we go for anti-VEGF, steroids, intravitreal steroids, or subtenon, or suprachoroidal injections of the steroids. And then if there is any proliferative diabetic retinopathy, we straight away go for laser photocoagulation, but we have not seen that how many people are having good compliance with the control of the diabetes and control of the associated risk factors with the diabetes mellitus. So this is very important. This is not only the function of the physician, but this is the function of an ophthalmologist also who is dealing with these patients. So the study results suggest that diabetic retinopathy has a strong association with poor metabolic control along with hypertension as well as duration of the diabetes mellitus. Thank you very much.
Data on CMAB in treatment of wet ARMD and Russell Hall Hospital, Delhi. Shazad.
Thank you very much, Mr. Chairman. Good evening and Assalamu alaikum, ladies and gentlemen. I bring you greetings from British Pakistani Ophthalmological Society, as well as Medical Retina Association of Pakistan. For those of you who don't know me, my name is Shazad Shafkat. I'm a retina lead and consultant in Dudley, West Midlands. If you look at the program, the last presentation in the program is mine on dry AMD, but these slides are quite long, so I have the permission to combine that time with this time, and this presentation will be longer than 8 minutes. With your permission, sir. So I'm going to talk about faricimab real-world data, and I've got some real-world data from my own department as well. These are my disclosures. The relevant one is that I'm a consultant for Roche. So I'm going to talk about FAR-WIDE, which is a neovascular AMD retrospective real-world study from UK. This is collective data from 21 NHS sites collected by going through the Medisoft electronic medical records system. Faricimab was approved in the UK in May 2022 for the treatment of AMD as well as DMO. Faricimab, as you know, is the first-in-class bispecific antibody for intraocular use. It includes VEGF-A, anti-VEGF A molecule, as well as an Ang2 inhibitor. If you look at the faricimab molecule, it contains of 2 long chains and 2 short chains. It has an anti-VEGF-A antibody fragment, which neutralizes VEGF-A, which is the most important cytokine in neovascular disease, neovascular retinal disease, including wet AMD. And it has an Ang2 inhibitor antibody fragment as well. And we'll see how that plays a role in inhibiting neovascularization and leakage in the retinal vessels. The crystallizable fragment, the modified FC segment, is there to make the molecule less immune reactive in the eye. So to reduce its autoimmunity, this molecule is added, this bit is added to the molecule to reduce its immunogenicity. So under normal physiological conditions, Ang1 is released from the platelets as well as from the pericytes. Ang1 then combines with and attaches itself to Tie2 receptors. And this tyrosine kinase immunomodulated factor 2 then gives rise to a cascade of events which are all anti-inflammatory and vasoprotective. They cause tightening of endothelial cell junctions. They make pericytes more mature. They recruit pericytes around the capillaries, and the end result is vascular stability and reduced risk of leakage. In neovascular disease, whether it's wet AMD or diabetic retinopathy or vein occlusion, there is upregulation of VEGF-A. There is also upregulation of Ang2, angiopoietin 2. So angiopoietin 2 then attaches itself to Tie2 receptors, Tie2 receptors. And that means that there is increase in Ang1 levels, Ang2 levels in the retina. So the cascade of events that follows this inhibition of Tie2 receptors gives rise to leakage from the endothelial tight junctions. It leads to increased inflammation, leukocyte migration. The pericytes, they undergo apoptosis, so decrease in number of pericytes, and the end result is vascular sprouting and neovascularization. Ang2 not only suppresses Ang1 by inhibiting Tie2 receptors, it itself also sensitizes the endothelial cells to tumor necrosis factor alpha, which is another cytokine which is upregulated in vascular disease in the vitreous. Another thing that happens is that there is a deposition of fibronectin, which is a pro-inflammatory protein in the cellular matrix of the retina, and this causes fibrosis and epiretinal membrane foundation. And we've all seen chronic diabetics with ERM formation. The cause of that primarily is fibronectin. So again, fibronectin levels are also reduced by faricimab. So one of the novel things that faricimab does, and it is now being reported in the real world data, is that you see much less epiretinal membrane formation in patients who are treated with faricimab compared to other anti-VEGFs like aflibercept. So coming back to the far wide data, the UK data from 21 hospitals, the patients were included were those who had had at least one injection of faricimab. They didn't have any concomitant diabetic eye disease. They were all 50 or above in age. And then they were divided into treatment naive eyes and treatment experienced eyes, people who already had some form of anti-VEGF injections. If you look at the demographics and the baseline characteristics, the majority were, the mean was 80 plus. Age group, there was a preponderance of female patients in this cohort. The vast majority were white, British or white other. Only about 5% were non-white individuals, African Caribbeans, Asians and others. And there was quite a substantial group of patients who had not revealed their racial details. It was a voluntary questionnaire and people could opt out. So it doesn't mean that in 23% of the patients' data wasn't collected, but they refused to answer that question. If we look at the makeup of the cohort that had wet AMD, it was also looked at the deprivation level of the patients, or looking at the index of multiple deprivation deciles. So this depends on which areas the people live in, what level of education they have, what level of income they have, just to see which socioeconomic group they belong to. And as you can see in AMD, there's not much separation between the most deprived and the least deprived patients, because it's genetics that plays a role. Whereas when you look at diabetes data that was also collected as part of far wide, you will see a difference in that people with the less affluent areas and most deprived areas, there was a preponderance of that in those patients. Whereas in AMD, we know it's mostly genetic based. Approximately 84% of patients included in the trials, or in the study, I should say, were previously treated, and the vast majority had been treated with aflibercept, followed by ranibizumab, Bearview, Avastin, and ranibizumab biosimilars. So we have now 2 biosimilars available in UK, and increasingly hospitals are using biosimilars and switching their ranibizumab Lucentis patients to ranibizumab biosimilar. If we look at the duration of anti-VEGF treatment pre-index, index was the first injection of faricimab, so anything that happened to the eye before the first injection was called pre-index. The mean was 3.4 years. So most of these patients had been treated for over 3 years with one or the other anti-VEGF agent. The total number of injections pre-index were 25.8, so nearly 26 injections per person. So you can see how advanced these cases would have been. Although about 70% of patients had only had one type of anti-VEGF, there were groups of patients who had had 2 or even 3 previous anti-VEGF injections. The mean follow-up was approximately 4 months. So this is first cut of the far-wide real-world data in UK, and it's been published. And as you know, the loading dose is 1 injection a month for 4 months. So practically, these patients had 4 months of injections. Eyes received a mean, of approximately 4 injections in that 4 months. The treatment naive patients follow-up is around 3.7 months, whereas the previously treated patients was 4.5. At least 6 months of follow-up in 18% of treatment naive and 25% previously treated patients. And injections per patient, 3.5 in the naive group and almost similar in the treatment experienced group. So 98% of treatment naive eyes and 97% of previously treated eyes remained under faricimab therapy within this short period. If we look at visual acuity improved in treatment naive patients over a course of 6 injections, you will see that 26% of naive eyes and 44% of previously treated eyes had baseline visual acuity of 70 letters ETDRS, which is equivalent of around 612 vision in Snellen. And so, a big group of patients had reasonably good vision, 612, but then there were patients who had vision of less than 34, that's less than 660, and 35 to 55, which is between 618 and 624 vision. So, there were patients included with less than 660 vision. In UK, we start treating them even if their vision is 696, which is roughly the equivalent of counting fingers 3 meters. We're still allowed to use anti-VEGF agents. If you look to the right side, the mean visual acuity changed from baseline after each injection, and you can see that with each injection, the mean visual acuity from baseline was increasing between 2.5 to nearly 6 letters, which is almost the same as the pivotal landmark Tenaya and Lucerne trial. 2-year data showed around 6 letters, around 5 in Tenaya and around 6 in Lucerne. Obviously, patients who were treatment naive did much better because they had less duration of disease and less chances of fibrosis. And patients who were previously treated had stabilization of vision, really. As you know, some of them had been treated for over 3 years prior to their index injection, the first faricimab injection. So far-wide is real-world data evaluating treatment outcomes of faricimab in the UK, and real-world data is an important tool to understand the treatment response in your cohort of patients, in your group of patients that you treat. It's looking at the results in your patients. It's also looking at any complications which may not have occurred in the pivotal trials. So these studies are very important. They're called post hoc or phase 4 trials or phase 4 studies. So at faricimab initiation, approximately 1/4 of patients' eyes in the study were treatment naive. The majority of the previously treated eyes had received aflibercept. We look at the effectiveness. Vision improvement in treatment naive eyes was around 5 ETDRS letters over 5 injections, which is very similar to the pivotal trials. Vision was maintained in previously treated patients. And we look at the treatment pattern, the mean treatment interval was extended to 8 weeks after the 4 injections in naive and previously treated patients, and 98% of naive and 97% of experienced eyes remained on faricimab treatment. There weren't any adverse events reported in far wide. So I've just mentioned here the adverse events that were reported by Tenaya and Lucerne, and they were cataract, conjunctival hemorrhage, vitreous detachment, intraocular pressure release, increase, vitreous floaters, eye pain, and retinal pigment epithelial tear. The most serious adverse reactions were uveitis or inflammation, seen in 0.5% of patients, endophthalmitis 0.4%, and again vitritis 0.4%. But there were no cases of ischemic occlusive vasculitis, which is the thing that we dread the most, especially after the brolucizumab trials. Just a cautionary word about retinal pigment epithelial tears. Obviously, they were slightly higher in Tenaya and Lucerne compared to aflibercept. So the recommendation in the UK is that if you have a large pigment epithelial detachment, which is described as 500 microns or higher, and you have a fibrovascular component under the pigment epithelial detachment, which is 50% fluid and 50% fibrovascular proliferation, you can use faricimab. If it is less than 50% fibrovascular component and more serous component, then the risk of RPE tear is high. So we usually don't start faricimab in such patients. Now, again, with brolucizumab in hindsight, and as you know, we are not using brolucizumab anymore in the UK because of the very small risk, but the real risk of patients developing ischemic occlusive vasculitis, retinal vasculitis. Immunogenicity of any new drug is extremely important. So we know that there's a potential for immune response in patients treated with faricimab, like all other anti-VEGF agents. And after dosing up to 2 years in Tenaya and Lucerne, treatment emergent anti-faricimab antibodies were detected, and approximately 13.8%, nearly 14% of patients with neovascular AMD had antibodies to faricimab. The incidence of serious ocular adverse reactions in anti-faricimab antibody positive patients was around 6%, and in antibody negative patients was 4%. So, you know, I mentioned that the faricimab molecule has a FC fragment, that is to reduce the immunogenicity of the drug. So most anti-VEGF agents, including going back to faricimab days, Lucentis days, also had the FC fragment. And that is there to reduce the antigenicity. So the drug is not picked up by body's immune surveillance system, and it doesn't recognize it as a foreign protein. So anti-faricimab antibodies were not associated with any impact on clinical efficacy or systemic pharmacokinetics. Both faricimab and aflibercept are well tolerated with low incidence of serious immune responses. So I'm now going to share my own data from the department. I was the first to give the very first faricimab injection in National Health Service in the UK on 5th of July 2022. So what we follow is the same principle and same treatment protocol regimen as in the pivotal Tenaya and Lucerne trial. So we start off with 4 injections, a loading dose of 4 injections once a month. The 5th injection is given 2 months after the 4th injection. And then depending on the findings from baseline, post-4th and post-5th injection, we then decide when the 6th injection is going to be, whether it's going to be Q12 or 3 months after the 5th, or is it going to be 4 months after the 5th injection. So we can extend up to 16 weeks, and if we If we feel that the patient has improved significantly in terms of ETDRS letters gained and reduction of central subfield thickness, then we may decide that the sixth injection will be at 16 weeks. So our resource was our Medisight electronic patient record system, and all our measurements are done on the Heidelberg Spectralis OCT machine. Data was collected from 1st of July 22 to 30th of June 23. We collected all the demographic data from the patients. Instead of best corrected visual acuity, I will say best recorded visual acuity, because we don't have, like trials, we don't have a optician optometrist sitting in doing refractions of all the patients and getting the up-to-date vision. So it's best recorded visual acuity in our case. Obviously, we did macular OCT scans, and we looked at the outcomes in terms of best corrected visual acuity improvement and OCT improvement during the audit period. Obviously, we also were looking out for any adverse events. So 114 injections were completed with 20 patients in 9 months audit time ending June 2023. Treatment naive were 11. 9 patients were switched, 5 from Lucentis, and the rest were Eylea switches. So if you look at the plot, the pre-treatment group, the treatment experienced group is in blue, and the treatment naive patients are in orange. So you will see that this is best corrected visual acuity pre and post treatment. So the range of best corrected visual acuity improvement from baseline in this whole cohort was 2.5 to 10 letters, both groups included. But if we look at the treatment naive group, the improvement was 5 letters, and drug switches 1.5. Again, that correlates with Tenaya and Lucerne, where the improvement in Tenaya was around 5.5 letters, in Lucerne was 6.5 letters, and the drug switch patients were around 1 letter improvement. If we look at central subfield thickness, pre and post treatment, pre-treatment is in blue, and the final subfield thickness is in orange. So mean central subfield thickness improvement from baseline was 91.5 microns. The treatment naive patients did well, 131 microns, and the drug switches just around 36, 37 micron improvement. For comparison, in Tenaya and Lucerne, the improvement was around 148 microns. So very similar. This is just showing one of the patients that improved from 35 letters to 50 letters best corrected or best recorded visual acuity, and the accompanying OCT retinal scan. You can see the improvement. And here's a patient who was treatment experienced. You can see subretinal fibrosis from previous years of anti-VEGF injections. And although the patient improved, and you can see much less hyperreflective foci compared to the previous scan, and much less intraretinal fluid, but the visual improvement was only less than 1 Snellen line visual acuity, 3 letters only. So to conclude, real-world data is important. It always shows less impressive results compared to the pivotal trials, and that's usually because of protocol deviation. Protocol deviation is when patients don't have the requisite number of injections in that period. Like, for example, 1 injection a month for 4 months. There may be reasons, and they usually are either related to hospital or the patient not turning up because they were unwell. Patients, they're elderly patients, they have falls, they feel unwell, they have angina, we have to stop the treatment for a period of 3 months at least. Or hospital, doctors go on leave and their clinics are moved, and somebody misses the point that these are retina patients, and they have specific periods of time that they have to come. Other possible causes, cataracts, dry eyes, which would be looked at and treated in pivotal trials, but sometimes overlooked in a busy NHS clinic. Usually, we are looking at a small sample size, so we can't extrapolate all the results onto pivotal trials. And in the pivotal trials, and that's why, we see a difference between Tenaya and Lucerne. And usually the US FDA specifies that you've got to do two things. You've got to vary the cohort of the patients in the trial. So most trials will have two arms. One is USA and Canada, the second is rest of the world. And you will see a difference between the results as well because of how well off the patient is, the socioeconomic status. But also comorbidities vary between different groups of patients. So that's why there's a disconnect between real-world data and pivotal trials. As I said, large serous PEDs in Tenaya and Lucerne trials, they showed slightly higher risk of RPE-RIP compared to Eylea, 1.3% versus 0.35%. For comparison, the retrospective analysis from the three pivotal phase 3 studies of Lucentis showed 1.8% risk of PED. And just want to leave you with the breaking news that in September, NICE, which is National Institute for Health and Care Excellence in the UK, gave the license for use of RVO, faricimab in retinal vein occlusion patients based on the Balaton and Camino trial. Thank you very much. So the usual reason for switch is the frequency of injections or what we call treatment failure. Now, different studies describe treatment failure slightly differently. For example, in terms of the Lucerne and Tenaya and Lucerne trial, their treatment failure was a worsening of central subfield by 50 microns compared to the average of last two visits, or worsening of vision of 5 or more letters compared to the average of last two visits. But it was an or, not and. If you look at the new data coming out for Eylea high dose, they've actually combined the two together. So it's more difficult to switch. But that's a little nuance in their study. I'll take any of the questions at the end, maybe.
Shazad, is there any head-to-head study between this drug and the previously like Lucentis and Eylea?
Yeah, so the Tenaya and Lucerne study is a head-to-head trial between two different doses of faricimab, 3 and 6 milligram, and aflibercept, 2 milligram, 2 monthly injection.
Okay.
So that's a head-to-head.
Thank you.
Okay, thank you, Dr. Shahzad Shafqat. Now I'll request Professor Tariq Aziz for his presentation on geographic atrophy. My request is for the speakers to please stick to your time. The 10 minutes is the time for each presentation. Thank you.
Thank you very much, Shahzad. You are a really asset to us whenever you come to Lahore, and you are doing a great job for Medical Retina Association of Pakistan as well. We congratulate you that you are the first person who started this faricimab trial in England. This is a real honor for us as well as a Pakistani. And आपसे रिक्वेस्ट होगी कि कभी कभी कराची भी आया जाया करो, ये भी आपका मादर वतन है. And because of your outstanding capabilities in the field of medical retina and the pioneering this thing in England, and also you also share your knowledge with us in our medical retina group, the Executive Bureau of the Medical Retina Association has decided to give you the Leadership Award. Ladies and gentlemen, Shahzad Shafqat is a consultant retina lead, Russell Hall Hospital in Dudley. He is an honorary senior lecturer, University of Birmingham, and qualified from the King Edward Medical College. आज अपने ये इसी शहर में बैठे भी हुए हैं. He's done his medical retina fellowship in Birmingham, and he's also a lead services providing in Macular Society of Clinical Services in England as well. And he is also an active member of Medical Retina Association of Pakistan. It is a great honor for us from the platform of the Medical Retina Association of Pakistan to award Shehzad Shafqat the Leadership Award of Medical Retina Association of Pakistan. Ladies and gentlemen, give him a big hand. I will request President-elect OSP Center, P.S. Meher, to please hand over this award to Shehzad Shafqat. Please. Ladies and gentlemen, I will take very quick on this topic. Geographic atrophy has always been a challenging task for everybody, whether you are in Dudley, whether you're in Pakistan, whether you are in States. It's very difficult to treat at times, and you really feel frustrated कि यार इसका करना क्या है? And many people, they mistreat this problem. What is geographic atrophy? ये है क्या चीज़? ये क्या बुलाए? What is the challenge? It's a severe form of dry ARMD, sharply defined area of retina cell loss, preferably photoreceptors loss, and leads to severe visual impairment. And it's a very challenging task. It's a very chronic progressive disease of macula, and it is related to a severe form of dry ARMD. And it is relentless, irreversible eye disease, and it usually affects one eye more than the other, but it usually affects both eyes, as far as we know, the studies today. Although we don't have any studies to share with, as Shehzad has 114 patient study, and they have been injecting Frezimab for the last 2 years. Frezimab has just been introduced. इस लाहौर कॉन्फ्रेंस में इसका लॉन्च है, and it was introduced last month. So we don't have any data whatsoever to share with you, but hopefully when you come next time, preferably in Karachi, we will certainly share with all the data. And so we cannot share anything about Frezimab today. So coming back to the subject, it's the best thing to identify the geographic atrophy is the autofluorescence. Is the most popular non-invasive modality, and almost not very expensive in our part of the world. Currently, there are about more than 5 million people are affected from geographic atrophy, and it usually, as I said earlier, usually affect bilaterally one eye more than other. So this is the criteria of the geographic atrophy: at least 250 micron in diameter. It could be round, cluster-like shape. It is usually sharp delineated. Hypopigmentation or depigmentation, retinal pigment epithelium, and usually you can see the choroid behind it. This is the pattern of the geographic atrophy. It starts from the periphery and it invades inwards. And usually you will see the patient can see pretty well because of the central sparing of the macula, but eventually it affects the macula as well. Recently, the drug has been introduced in States. It is not available in UK, I suppose, and it is very costly medicine, which is specifically been designed for the geographic atrophy. Cypher uska naam hai, and it's a complement inhibitor basically, and it's very expensive. It's about $2,138 US of one vial. And if you can arrest this disease at the early stages, it's a good news. But if it advances, then it's very difficult to control. This is a typical geographic atrophy. अक्सर लोग इनको inject कर रहे होते हैं, this and that, Lucentis and Eylea and all that, but it never responds. And again, you can see the cleanly well delineated area surrounded with a central atrophy. This is another form of geographic atrophy. This is the typical progressive crescentic shape, as I described earlier. Little bit of functional macula in the middle, but eventually this macula will be invaded. And this is the OCT picture of the geographic atrophy. This is a typical pattern of the a geographic atrophy in fluorescein, and you can see that identical picture. Typically, it affects the central macula. These are the other picture, crescentic shape. This is a usually the photoreceptor degeneration as a marker of geographic atrophy progression. So whenever you do the OCT, it may not be helpful, it could be helpful, but usually with the introduction of artificial intelligence, people are more relying on that, but do not rely more on the artificial intelligence. It may lead you at time. Uh, we had another speaker from India, Rajvardhan, who nahi hai yahan pe. He will be talking on this artificial intelligence in diabetic retinopathy, but I think he didn't get the visa or somehow, so he's not here. So that will be good for us learning curve. So artificial intelligence assisted OCT, it could be helpful, it could not be helpful, but you should not rely 100% on this matter. Then the treatment plans, as I mentioned earlier, recently FDA has approved this medicine, but as I said, it's only available in the United States. It's very costly, and it's C3 inhibitor basically, as you use to inhibit the platelets to prevent hemolysis. And there's another drug as well, but I was told it's very toxic as well. And one has to be very careful. It hasn't been introduced, but once it's introduced in Britain, then obviously Shahzad will let us know what next coming to that. Be careful. We must be very careful with the use of artificial intelligence. However, not to over rely on it. We need to learn how to surface it basically. So currently shows that progressive of the disease doesn't stop it with this drug, but it doesn't reverse it. Remember, to work best to treatment initiated the disease, extrafoveal lesion benefit the most with this drug. But as we said, we don't have the data available from states as well, so we cannot talk about it, but the worst effect is the ischemic optic neuropathy in this drug. So the question is how the era of geographic atrophy therapy will unfold. The time will tell us, and what gets to conversation started. So we have started the conversation on this topic. Let's see where it leads. Thank you very much.
Just for Mr. President, my name is mentioned as talking on dry AMD at the end of the session. I'm not doing that. That's why I took extra time in my previous. So I just want to make a few comments about dry AMD treatments. So originally, the first drug that got its license was Syfovre, and then Izervay got its license in US. So in USA, they have given more than 75,000 injections of the original drug Syfovre. About 6% of patients can develop anterior ischemic optic neuropathy, and 4% to 6% of patients can have reactivation of wet macular degeneration or development of wet macular degeneration on the edge of the GA lesion. So these are two issues that are still unresolved. The bad news is in September 2024, the European Medical Agency, EMA, did not give Izervay or Syfovre the license for use in dry AMD. So at the moment, it's only available in the US. And I've spoken to some researchers who were, leading the pivotal trials on these two drugs, and they're so scared of using Syfovre or Izervay that one of them said, "I only use it in the eye which is lost eye of the patient. First injection is given in the perception of light or maybe 696 vision eye. If they don't have any reaction, then I start treating the fellow eye, the better eye, because all the reports that have come out of anterior ischemic optic neuropathy have been after the first injection, which is different from the occlusive vasculitis seen in brolucizumab. In Bearview, the patients who lost their vision It could happen after first, third, fifth, or seventh injection, whereas with Syfovre, the first drug, it was always after the first injection. So you can see how problematic it is. The second problem is that these are monthly injections. There's no treat and extend. The third problem is that they don't actually give rise to improvement in vision. What they do is they slow down the progression of geographic atrophy. So how many injections will you give, and what sort of benefit will the patient get? Despite that, it's approved in US, both drugs, and the current state of affairs is that they're really scared about giving the first injection. You should see the disclaimer before the first injection is about 3 pages long, and only the most desperate patients want to have it done. Thank you.
Now, next speaker is Professor Rashid Kamal, but I think he's not here. Dr. Usman Saeed, his presentation on results of TENAYA and RHINE trials. Initial results of faricimab of A1LE X trial in wet AMD and DME.
Hello, Assalamu alaikum. My name is Usman Saeed. I'm a consultant ophthalmologist at the Royal Liverpool University Hospitals. My sins was the principal investigator of TENAYA and AVONEL X, which were the pivotal trials for wet AMD in the UK, and we were part of the European subgroup of faricimab trials. So I was also the co-investigator of RHINE, a lot of work, and that's me seeing a patient. And my disclaimers are that I've had financial disclosures from Roche, which I was a consultant with. What we already know is anti-VEGF's work. So might it be Avastin, Lucentis, Aflibercept, Vabysmo, and Beovu, they all work. When did they start? Started from 1989, started into clinical practice in 2007, then started really the anti-VEGF took off in around 2011, 2012 with the introduction of Avastin and then Lucentis. And we worked a lot with the IVAN trials, for which I was a co-investigator with as well. And Simon Harding published his pivotal findings on the IVAN trials in the UK. Now, what's the best thing to do? Would it be a fixed regime or an individualized regime? You've got pros and cons for both. With a fixed regime, you can probably give injections every month or every 2 months, but the thing is that you might be over-treating the patient or you might be under-treating the patient. If you over-treat the patient, you're giving too many injections. If you're under-treating the patient was going to lose vision. Okay, so you've got to tailor the need and the frequency of the treatment to the individual need of the patient, and that's what the bottom line is. Is there a genetic association? We don't really know. We don't have that much data, but individualized treatment works, and we've seen that with the Pronto trials, where gains in visual acuity were seen up to 12 to 24 months after treatment, and gains of 9.3 to 11.1 letters were observed with Lucentis. So, what can you expect with with persistent anti-VEGF treatment? Is you can expect visual gains to be maintained over a number of years. The thing is, you've got to give injections fairly regularly. With injections of Lucentis, you had to give an injection every month to get a result like that. So after that, what came was Aflibercept. So they said, okay, if you give first 3 injections, and then after that, 2 monthly injections, and you probably will get the same result. So they did the trials, and yeah, absolutely right. After the first year, you give 2 monthly injections, and you're getting the same visual results with Aflibercept compared to ranibizumab. Central foveal thickness decreases. You can see a sawtooth effect with ranibizumab, but much more smoother effect with Aflibercept. Now that's going to be important, because when I show the slides for Vabysmo, that sawtooth effect becomes even more flatter. So, what we've been doing is we've been treating our patients with aflibercept, and aflibercept, we switched over from Lucentis to aflibercept, and all our patients started going on to aflibercept. Now that Vabysmo has been introduced, we've been seeing the same kind of adoption patterns that we saw with aflibercept. So all these patients over here that we've got, we started from 2022, and the pattern of Vabysmo adoption is increasing, so more and more. So we've got recently published retrospective reviews of real world data, which as others very very eloquently described. And what doctors wish for is an effective drug that works, and you don't have to give that many injections, and it works and it keeps the vision stable. That's what all the doctors want. You want quality, you want quantity of injection treatments decreased per patient. You want to need to extend the duration of treatment, and you want to keep the vision stable. So these are slides that Shahzad has shown before, so I'm not going to go and repeat those. The Tenaya trial was the seminal anti-VEGF injection trial in the UK and Europe. These were the key inclusion criteria, and these were the treatment protocols. And if you just have a look, this was the treatment protocol for Vabysmo, and this was against aflibercept 8 weekly. So Professor Maher said that, was this a head-to-head? Yes, this was a head-to-head trial of these two patients. So you had 4 injections of Vabysmo, and then you had multiple arms in which you extended. So you had a 12-week extension arm, then a 16-week, then a 20-week extension arm after the first 4 injections. And these were the criteria for determining Vabysmo interment treatment trials, and the baseline characteristics were fairly similar in both the groups with aflibercept as well as Vabysmo. So, and these are basically the results that show what actually happens. That you start from over here, your vision improves, you keep on improving with Vabysmo, and you get a higher peak over here, probably because you're giving 2 agents. One is an anti-VEGF, the other one's an anti-Ang2. You get a higher peak over here, and then it's sustained over a long period of time. At 1 and 2 years, you're probably at the same kind of pattern, but with decreased number of injections, and we're going to talk about that a little bit later. So year 1 results and year 2 results, and this is a central foveal thickness decrease. The top one, the grey one, is aflibercept, in which you see a sawtooth effect. And if you remember the Lucentis data, there was a much higher sawtooth effect. With Vabysmo or faricimab, you have a much smoother kind of a pattern that once you've got the disease under control, it stays under control. And that's a similar pattern over 2 years. And basically, it works. And it works by reducing the intraretinal fluid, and you get more resolution of intraretinal fluid compared to aflibercept. What can you expect? You can basically expect 3/4 of your patients to get to at least 3 monthly injections. Both over here in Lucerne and in Tenaya in the UK and Europe, 3/4 of patients you can get to 3 months or more. In aflibercept patients, you can probably get them to about 2 months or so. About a quarter of them you can get to every 4 monthly injections and keep them stable in 4 monthly injections. At 2 years, the results are pretty similar, except that the number of patients who are more stable with 3 or 4 monthly injections is probably higher. So, DMO, the results of the Rhine trials, we're going to talk about pretty much the same things, the same kind of key inclusion criteria, but the inclusion criteria being central macular thickening more than 325 microns, BCVA between 25 and 73 letters, and diabetes type 1 or 2. And you had Vabysmo 8 weekly, Vabysmo PTI. This is not the political party. This is patient treatment interval, aflibercept versus aflibercept, and every 8 weekly aflibercept versus PTI versus Q8 treatment, and you pretty much got the similar results. So you got good results similar to aflibercept, but less number of injections and more duration between the injections as well. Similar results with the central foveal thickness or CST reduction with DMO, and results are maintained over a period of about 2 years. So the Liverpool experience that we've got is patients with wet AMD did data extraction in just a week before we came, and like Shazad, we use Medisoft, which is the better version of the more up-to-date version of Medisoft. We've got 6,407 patients. Some of them were excluded, and basically we've got a lot of injections, with about 6,000 patients that we've injected. Now, this is another kind of slide that we've got. If the vision's already up at, say, 75 letters, you're not going to get a much improved vision because you're already at that peak. You can't get 75 letters and then if your maximum is 75, you're just going to keep that as a maximum. You're going to get maybe 76, 77 letters, and that's it. But if you've got, say, 624 vision, then your vision's going to climb up like that. And that's what it shows, that stratified by baseline vision, your vision's going to improve depending on how much your baseline vision is. And I'm just going to show, run through a few cases which we started on. So case 1 is an anti-VEGF non-responder, 75-year-old male, mixed type MNV, and the vision is 57 letters. And you can see that there's some fibrosis over here, and you can see over here that despite injections, the patient still has subretinal fluid. And the MNV that you can see on the fluorescent angiogram over here as well. And this patient's had anti-VEGF injections. The subretinal fluid is still there. The patient still got a PED. Patient has 2 injections. There's still persistence of fluid. Still got a PED. 3 injections. You still have 38 letters vision, and still everything's pretty much the same. Now, at this time, we've switched to Vabysmo, at this point, the patient has 1 injection of Vabysmo at 35 letters. See what happens in the next. There you go. The fluid's almost all gone. The PED's getting better. You've still got some fluid, but the macula is pretty much, getting dried out. This is not what I would say completely dry, but I'd say getting dried out. The vision's gone from 38 letters to 54 letters, and that's what the visual acuity does. So this patient's been having aflibercept over here, vision's going down. You've had 2 injections so far, and the vision starts going up. So case 2 is a 6-week responder. Basically, what we're saying is this patient's responding to aflibercept. So you're given an anti-VEGF, you've got subretinal fluid. We know that this patient's getting injections every 4 weekly. 3 injections. We've got this patient completely dry. The vision 69. Everybody's happy. But see what happens when we start increasing the duration between the injections. So we've given 3 injections of aflibercept. We go on to 8 weekly as per protocol, and the fluid starts appearing again, and the vision will start to drop again. From 68 letters, the vision's gone to 60. So if we keep this on, vision's going to drop even more. So we then give patient 2 Vabysmos. Vision goes again to 68 letters, and then we're able to extend that duration between the injections again. So with 3 injections, you've got an initial increase, then the vision drops when you try to extend, and then you go on to Vabysmo, and you can extend the duration between the injections and keep the visual acuity gains as well. Okay, these are the patient-naive ones. These are doing really well. 82-year-old male, March 2022, peripapillary CNV, 75 letters. The patient's not got any treatment. We decide to observe. Patient comes back a few 6 months down the line. Patient's vision's dropped to 44 letters. We start giving the patient Vabysmo, and lo and behold, with 2 injections, all the fluid's gone. Vision's improved to 65 letters, and the patient's a very happy person. So at three injections, patient's vision improved to 70 letters. Almost driving standard vision as well, and this patient's a very happy bunny. So with the graph again, you see the vision plummeting down here. You give the injections, and the vision comes up again. So that's a very, very nice kind of result to talk about. Now I think we've run out of slides. I think I've probably run out of time. That says 0 minutes over there. Well done to me. Okay, thank you. Okay, any questions? Yep.
So I can see Swami giving 3 injections as the loading dose.
Four.
4.
Okay. Four for Vabysmo, both for AMD and for DMO.
So when I started looking at the far-right data, a lot of the hospitals were giving 3 injections. And I had a similar problem with my CCG. They said, well, you're replacing a aflibercept with Bracimab, and you want to replace a loading dose of 3 with a loading dose of 4? Are you mad? We don't have that kind of money. So I had to convince them that over a period of 1 year, it would be 2.5 injections less with similar visual results to what Dr. Mahir Professor Mahir was asking, the head-to-head trial. It shows that visually, they're both the same. So they're statistically significant, insignificant in terms of visual gain, but you can increase the gap between the injections. So you have to give, or you can get away with giving less number of injections. That's a superiority. So less burden on the patient, less burden on the treating doctor.
I think I'll have two comments on that. One comment is basically when you go to the CCG, that's in a very NHS England sort of way, that you've got to argue what's your evidence, and the evidence is that the trials that they ran were against four loading doses. So if you're telling me that you've got better evidence than that, then we can do it for 3. But because they haven't run any trials with 3, you can't really argue. You can only say trials say 4 injections over 4 months. That's one. That's big, a huge, big, lot of evidence base that you say, okay, you've got 4 injections. The other thing is exactly as you said, over a course of, for example, 2 years, you might be giving 8 or 9 injections. But with aflibercept, you're probably given about 12 injections. So that's where the cost effectiveness comes along. Another thing is, when you're talking about these patients, some of these patients will be living for another maybe 5 years. And you don't want them coming into your clinic every 2 months. You'd want them to come maybe 3, maybe 4 times a year. And if that's what they're happy with, that's what I'd be happy with as well. You don't want an 80-year-old patient coming into your clinic every 2 months or every 6 months. And actually, there's some data that we're publishing with one of our newly joined consultants called Salma Babikar, who analyzed all of our data and basically found that if we looked at our patients with aflibercept, on average, the aflibercept gave us about 6 weeks on average as median with those fluid-free intervals. Whereas with Vabysmo, we had 10 weeks as fluid-free interval with Vabysmo. Now, that's all a mixture of patients, with all the patients who were high flyers and frequent injectors and non-responders and this and that, as well as the treatment-naive patients. But if you look at treatment-naive patients only, then you're looking at those 3 months and 4 months gains.
Okay, thank you.
Thank you.
Now I'll request Professor M. Afzal Bodla for his presentation on the comparative study of CSCR using intravitreal ranibizumab, patisiran, and aflibercept. Highlier.
Bismillah ar-Rahman ar-Rahim. This is a small study using the intravitreal ranibizumab and the bersuat alia for the CSCR cases. I do not have any financial affiliation with any. The medical retina services has become state-of-the-art technology with the latest diagnostics and evidence-based expertise. Central serous retinopathy is a known disease, and it is one of the four most common diseases which can result into loss of central vision. And one of the main causes is the choroidal vascular permeability, which can lead to the CSCR. Now, our use on the CSCR was to rule out the efficacy and better results between the ARIA and PATRIZA in the management of the central serous choroidal retinopathy. We have adopted two ways of investigations. One was the DFA and the other was OCTA. Now, this is a picture showing the changes in the OCT which appear in the form of a focal pigment epithelial defect, while on the fundus fluorescein angiography, you can have the fluorescein angiograph revealing a pinpoint hyperfluorescence area. Anti-VEGF vascular endothelial growth factors have been hypothesized to be a treatment option for the patient having the pathogenesis of the CSCR, including the choroidal hyperpermeability, and anti-VEGF therapies have been proven to be successful in treatment diseases like degenerative age-related macular degeneration, diabetic macular edema, and retinal venous occlusions. A retrospective interventional cases studies are conducted at both Care and CMH Institute of Medical Sciences, Multan, and we have 20 eyes of 20 patients, in which in 10 eyes we used the PATRIZA, and in 10 eyes the ILIA was used. Normally, when you see the vial, it is written as a 10 milligram per ml or 40 milligram per ml in the area, but practically the vial volume in PATRIZA, that is 0.23 ml, and in ILIA it is about 0.27 ml, and the given dose in PATRIZA was 0.23 ml, while in ILIA it was the half dose which was actually given from the vial, that is half dose than the PATRIZA. Inclusion criteria was both males and females. Age group was between 20 to 45 years of age, and exclusion criteria was other conditions from CSCR. The male was 13, the female 7 patients. Age range was 25 to 45 years. Now, this was the results taken was as improvement in the central visual acuity and the reduction in the central macular thickness. The mean central macular thickness, which was reduced in the PATRIZA, that was 17%, while the mean reduction in the central macular thickness in the ILIA, that was 45%. And these are the p-values showing the reduction in the central macular thickness as well as improvement in the visual acuity. And statistically, we did the pair test, and pair test was to see the comparison between the effectiveness and both drugs, which was less than 0.005. The central macular thickness in the PATRIZA, that was mean was 72, while the standard deviation was 56, with a p-values of 0.003. Similarly, the ALIA showed the standard deviation of 0.0120 and with the p-values of 0.004. Now, there was a 70% reduction in the central macular thickness of PATRIZA, while 45% reduction in central macular thickness of ILIA, and the visual acuity improvement in the PATRIZA was 25%, while the average improvement in the visual acuity of the ILIA, that was about 35% or 45%. So, coming to the conclusion, the present study suggests that both anti-VEGFs are almost equivalent in terms of anatomical outcomes in CSCR. ALIA has much more better results with standard dose as compared to PATRIZA in improvement of the best corrected visual acuity and central macular thickness reduction. ALIA tends to be more effective with the better prognosis, having reduced rate of complications both ocular and systematically. Thank you very much.
Can I ask the question? Okay, first thing is the nature of CCR patient. Are you dealing with acute cases, chronic cases?
Actually,
recurrent cases?
in our study, we had all type of cases, and practically they were having a central macular thickness starting from 300 up to 500 macular thickness, and they were all type of acute and chronic cases.
Because if I remember, and there are these two gentlemen studying here from medical retina division, is that the if you look at the natural course of the acute, almost 80-90% will do well within 6 months. As only the 5-10% will have the problem, and small percentage can have a recurrence. Is the problem is the chronic one, which occurs after the 6 months, and in which some of these cases we have dealt with with other sources. I am never sure actually what is the role of anti-VEGF injection in CSCR. I never understand it. So I don't know, sir, please.
The practice, this is a basic study, and we are continuing with this study, and naturally we are adding more and more cases, and ultimately we will have better results.
I'll usually ask for a non-invasive test like OCTA, and if there's a pattern of vascular or neovascular membrane, then I'll probably label it as a CSCR with neovascular membrane, and those patients I will treat with Patirza or anti-VEGF agents. However, if there's no evidence of MNV or CNV, then what they get is a half-dose PDT treatment. If the PDT fails to, if the CSR fails to resolve within 6 months, and the visual acuity is still affected, I think that's probably the pretty standard treatment in the UK anyway, and I think Shahzad will probably add some more.
See, the problem is that we don't have a Visudyne here anymore in Pakistan, and therefore we cannot apply the PDT. So this is gone. There's a very small percentage of CSCR case where they will be complicated by the this membrane, CNV. And that I can understand it, that you can, there's a role of anti-VEGF. But if we don't establish the CNV, then what is going to be the role of injecting this medicine? That's what.
Just a couple of comments. Excellent presentation, sir.
Thank you.
What we do is we also wait 3 months unless the patient has significant severe symptoms.
Afzal, I think it will be very useful if you divide your patient among the type of CSCR, that rather than saying it's a mixed patient, because then it can, because you see, Eylea has a better prognosis in these cases. We want to find out why. And so if you classify them acute, then we may be have a little bit more information. Yes, Siddharth.
So as Usman was saying, we wait 3 months, and 90% will get better and resolve on their own, just by making sure that they're taking steroids. We ask them to take steroid sparing agents, if they're taking any anabolics or anything like that, or if they have a lot of stress, then obviously we tell them to calm down and make sure that they have sleep cycles and all those things to reduce endogenous production of steroids, which causes CSR reversals. But secondly, I always ask for an OCT and look for the double layer sign, which is a biomarker for a coupled membrane. If they have it, then they can have anti-VEGF. But if they don't have that, I then ask for a fluorescein angiogram. The fluorescein angiogram shows a single spot, which is extrafoveal, like one of Goldberg's patients
Yes.
have like a single spot. That can very easily be treated by conventional laser. It's extrafoveal. Problem comes when they have multifocal CSR or a recurrent CSR. There's a lot of atrophic RPE around that. That causes problems, and then like you, we don't have PDT as well. PDT is now only available in centers that are treating vascular tumors. So Liverpool is the center. That's where we send all our patients. Sheffield is another place. So if they are not treating hemangiomas and stuff, they don't have Visudyne. So our only recourse is either to use micropulse, or as we try in some of our patients, Pascal laser with endpoint management, which is also invisible burns, similar to micropulse. And it's some threshold laser to see whether it gets better or not. But as you rightly point out, the gold standard is half towards PDT.
So I have had a series of patients that had more than 6 month duration of not settling, and we gave them oral rifampicin, 400 milligram, single dose, and for 3 months at least. They did very well. The problem is rifampicin is not available in Pakistan. It's anti-tuberculous and is not available in Pakistan. It's a very, very strange thing.
So
That's why we're thinking.
there is another study using eplerenone
Yeah.
for the potassium-sparing diuretic, and it came out, and then there was a randomized control trial from Southampton University. They actually rubbished
Yes.
eplerenone.
Yes.
However, there are more studies coming out using a higher dose and a longer period, which they actually claim that it does work. And also people have had positive results with propranolol, beta blocker, showing good results in CSR. But these are small studies, and unless you have a randomized control trial,
So we got a good number of CSCR patients that we see, and I tell you, lots of these cases we struggle with. We have absolutely no idea how to deal with these patients.
Send them to Liverpool. That's probably the best treatment. We've got PDT available, so we'll treat the patients. Thank you.
Thank you very much. Professor Shakib Anwar, his talk is on age-related macular degeneration.
Comment on the previous topic which was going on CSCR. Actually, we have to consider the diverse etiology of CSR also, because the things written at the end of the list are the stress, the competitive life, and all these things are also there. So sometimes the medications which are given, like Indrol is sometimes given for anxiety also, if you remember. So sometimes the medication which you don't know how they are acting indirectly on that reason, which is one of the last on the list of the CSR. So that might be helping. I've seen many cases in young age of 30 to 35, even ladies getting into, 2 days ago, a lady came to me who had a precious pregnancy at the age of 44, and in the 6th month she has developed CSR. She has a lot of stress. I don't know what could be the reason. She is little hypertensive, but well controlled, nothing else. So eplerenone, I have not tabulated or written anywhere, but I have treated a few patients who linger on more than 3 to 4 months, and they get better with eplerenone. Although they say it's of no use, but people have their individual experiences. So whatever works for the patient, I think it should be tried, remaining in the safe limits and monitoring the patient. So that's the beauty of the medical practice. All right, so a lot has already been said and being said in the past years of ARMD, and the problem is that there are 2 types, and only one of them we can really treat is the wet type and the geographic type. There are genetic things are also coming in, and there are trials going on in phase 3 also, which they claim are going to be a promise for the treatment of the dry or geographic type of ARMD also, along with the few things which Professor Tariq Aziz and Dr. Shahzad was mentioning. So it's a disease. In the beginning, we know we try to treat ARMD, but it is age related. So all those things which are age related, or they are going down, we are sure in our hearts that we won't be able to reverse it fully unless we change the name. If we label it age related, then aging is aging, and of course if something is aging, we can't totally reverse it, although we can treat the sidelines and comorbidities and something else like bleeding and SRNVMs, we can treat them. But once it has gone to its last stages of geographic or thinning, then probably we won't be able to reverse it. So I have a patient now, it's about 2.5 year patients. All of them I now use mostly. I have no financial interest or any affiliation, but I have mostly switched over to aflibercept because I see that I can prolong the injection gap. So there are quite a number of patients that I've been treating for the last about 4 years. I am using regularly this aflibercept, and there are a few patients who have been more than 3 years in diabetic retinopathy and DME who are have taken multiple injection, and by the grace of Almighty, I can confidently say that I have taken that gap to almost 3.5 months to even 4 months. But they come regularly. So it's uh, I mean, whenever they come, I do OCT on every second or third injection, and then I inject the patient within that period. And I've seen that the patients who don't get the injection, they have problem. But those who are getting a treatment at a regular intervals, they don't have a problem. And the problem is it's a very costly treatment, so every patient cannot get it, go and on, except for those who have insurances or those who are on the panels of certain institutions, they are getting it regularly. And they can also get OCT done regularly. So I selected one patient who has been regular in getting OCT, and it's a very interesting case. So it's a real world study. He's not a controlled patient. It's a real world study, and I can share that he came to me in May 22, and this was his first picture. And you can see that on the right side, he has a lot of hyper reflective material in the right eye with intraretinal edema and some cystic degeneration. And there's almost a complete destruction of the outer layers of the retina. But on the left side, there's a big cyst, some hyperrefractive material, and slightly less edema, but some cystic lesions here on the left side. And the vision was 1/60 and 6/18 actually almost. So I gave him an injection, and after 2 months, this was the picture that on the left side where hyperrefractive material was less on OCT, and now this time he brought a color picture. So okay, so on the left side you see the things are getting better. Even right got a little better, cystic disease, and this material is still there. The destruction is still there. We can't reverse it, but rest of the things started getting better. Then on 2 months later, again another OCT, and I had given another injection. Again, the left is still better, almost static, and the vision improved to 6/9. On the right, the vision improved to 3/60. Now he was religiously getting it, and this again, there was a little gap in OCT, but in between he got injections. And this was a little different picture from another center he got the OCT done, but still we can see that the edema is lessened on the left side to a great extent, and right also appear now slightly better. There is some here, but on the left side it's getting better. So it's still going good. So he got confident and he went away for about 5 months. He didn't come. And after 5 months, there was a gap of 5 months of injection. And see, his vision dropped to 2/60 here and 6/12 here on the left side. Again, a cyst appeared. Right? So at 5 months gap of injection, he had problem. So again, a cyst appeared, and on the right side also. Then got him injected again, and he started getting 6/9 on the left side, but still 2/60 on the right side. Started getting better again. Now this is real world thing. Now there is hardly any red. They turned to yellow here, and this portion of edema is also reduced on this side. All right. So the latest, the one but the last in the July that we did, you see how nice is on the left side. It's almost fine. 6/9. The right also gained another 3/60 vision. So he's comfortably going on here. Now if we compare the 2 years from 22 to 23, we can see a lot of improvement over 1 year. In 1 year, he got about 6 injections of aflibercept. And if we compare the 2 years record, and if we see this one and these two, you can see over 2 years, and they were about 10, not 11, 10 injections of aflibercept over 2 years. You can see the difference from here, and you can see these two. You can see a maintenance. I'm stressing on the maintaining of the vision. It is maintained, right? So that's more important. And This one is the latest, got in September. He came again, and he is almost slight. There was a gap again because of Hartal Vartal, roads were closed. He comes from Kashmir, and I was also in America in August and September, so he couldn't get his. It was my fault. He couldn't get his dose, and there was a little edema coming back here. So the point is that if the patient is regular in treatment and is coming, and you are giving even at 3 months or 3.5 months or even at 4 months, the patient stays the same. So the patients who do best are the one who treatment naive patients. They start early, and those presenting early, and those who avoid longer intervals between two injections, and who maintain healthy diet and healthy lifestyle also. This is also important. High blood pressure, high cholesterol, they also, aggravate these things. To maintain a good control over BP and this, and use antioxidants and vitamins. This is also my personal experience, that I do give antioxidants. And the people who take these vitamins over years, 2 years, 3, then I feel that they have a difference. It's not that just take one bottle and don't take again. So patients who have experience of worsening vision, they are the ones with more fibrotic and more hyperrefractive material in the beginning in the OCT. So you can tell who is going to benefit. If they're more dense material, then it's not going to go away. But if there's only edema or some cystic thing and structural changes not much, then they get better. And exudative fluid, degenerative, intraretinal fluid and subretinal fluid, and different treatment regime, bad compliance, going to this doctor, sometime Petesra, sometime aflibercept, sometime ranibizumab, sometime bevacizumab, then they don't do good. And then more than 8 weeks interval in first year of treatment. So first loading dose for at least 4-5 months, it should not be more than 8 weeks in any case. So that is important. So first year is critical. And then abrupt laser, one can find abrupt change in loss of letters, but this is normal with ARMD. You can always expect them. So the real world, not unusual for the patients to lose substantial vision even between conjunctiva. I've seen that the benefit the patient get in first 3 to 6 months is the maximum, and then it's kind of a plateau kind of thing. So you achieve in the first heat of that circle of the race. So in the first circle you achieve the lead actually. So if you lose that first circle of the race, then you lose. So a very close watch at the course of the disease during follow-up and critical analysis of OCT can help on make a decision for rational treatment, on counseling of patient accordingly. So you can tell the patient, this eye is going to be slightly better, this may not be helped, and you are going to have this much cost, and you will have to follow us properly and all that. Thank you very much.
Thank you, Professor Shigem. Any questions?
Well, we got your message. I think I should be able to. Can I just yes, the question to the point I want to make? You're absolutely right. The loading dose is very, very important. And all studies have shown whether and which are the whichever conditions you're looking at, whether it's AFD or PMO or RPO, you have to get the first 4 or 5 injections in very, very quickly. Then that determines the long-term prognosis of vision. But the point I want to make is that once you've given the loading dose and you start following them up, even with Eylea, there are treat and extend regimens that we follow. So it's not like fixed 2 monthly injection. That's the first thing.
Yes.
Treat and extend regimen available. The second point is that we must differentiate between your vascular fluid and degenerative fluid.
Yes.
So there are patients where you see a nice umbo and you see one small cyst, you see some hypertransmission defects because of RPE thinning and a complete lack of hyperreflective foci. So if there are no hyperreflective foci, which are a sign of activity and inflammation, and you can see the umbo and you can see hyperreflective transmission defects until the
window.
Yes,
Yeah.
window defects. That means it's degenerative fluid.
Yes.
You can still extend the interval going up to 12 weeks in case of IEF, up to 20 weeks with IEF HD, with the new IEF,
8 milligram.
8 milligram, and you won't have any problems. So the important thing is to recognize that it's not cumulative. Generally.
Yeah, exactly. Exactly.
So,
Well, I think everybody enjoyed the session, starting from Shahzad Shafkat and our friend from Liverpool, Tariq Aziz, and Shakib Anwar, and also our friend Afzal Boudla. So thank you very much, all the speakers. I think we should have a photograph before we disperse.
And sir, I would request that medical retina members to please remain seated just after this session. We'll have 10 minutes of talk together.